very happy to introduce Matt Quaife, who as of today is still officially a PhD student, and hopefully as of tomorrow no longer, as he has his PhD defense tomorrow. Matt won an ESRC PhD fellowship and joined the London School of Hygiene and Tropical Medicine as an MSc student, and then followed on doing his PhD in 2014. He did his field work with a Strive partner, Wits RHI, so we're very happy to have this. So without further ado, Matt, I'd like to welcome you to present your papers.
Great, thank you, Fern. Hello everyone, thanks for joining us. As Fern says, this is some work I did as part of my PhD, but in collaboration with Fern, based at LSHTM. My co-supervisor was Peter Vickerman, who's based at the University of Bristol. And we worked very closely in collaboration with Wits RHI in Johannesburg, specifically Sinead Delaney, Robin Eckel, and Maria Cabrera. It's I've tried to make this a fairly technically free presentation, so I'm just trying to get a few key messages across from our results. And this is some work we've done looking at preferences for multi-purpose HIV prevention products among different population groups in South Africa. And we look at people's preferences for different products, what characteristics of products they like. And we follow that through to a modelling exercise where we've tried to model the benefit that we might get from different scenarios of rolling out different types of products, and also accounting for the costs and cost effectiveness. As Fern mentioned, this is a bit of a whistle-stop tour through a big chunk of work. I'm more than happy to clarify anything at the end. If you can pop the questions in the little box, or I think we might unmute at the end or something, but I'd be more than happy to clarify anything that I skip over, because I want to get our key messages across. So our background and our motivation for doing this work in South Africa is that I'm sure many people know it's got one of the largest and highest profile HIV epidemics in the world. It's a generalized epidemic. And the prevalence in the general population, there are different estimates depending on which spreadsheet you use to work out what your prevalence is. But it's somewhere between 12% and 20% in the general population. Prevalence is increasing. That's partly due to incidence not reducing as fast as we would like it to, but also a huge scale up in recent years of antiretroviral treatment. In South Africa, it's a predominantly heterosexual epidemic. It means most transmission is between heterosexual partnerships. It's got some nuances which I'll keep reflecting back on. Women are 1.4 times more likely to be HIV positive than men, so women are facing a greater risk of being HIV positive. Adolescent girls are 8 times more likely to be HIV positive than boys of the same age. So there's been a real focus amongst Strive and many other groups of working out what risks adolescent girls face and how we can design programs to meet their needs. Another group with a particular needs of HIV prevention options are female sex workers. In our sample of female sex workers, the data I'll present is from just outside of Johannesburg. Now, some models have estimated a prevalence of up to 70% in Johannesburg. Others have estimated between 40 and 50%, others as low as 35% in other areas of South Africa. The main takeaway is that whatever your precise number of HIV prevalence amongst female sex workers, it's a very high number compared to any comparator, really. And why are we interested in this now? So for years, condoms were the only efficacious product to prevent HIV transmission. So if you're HIV negative, the only way you can keep your HIV negative status and face the pressures of life and sexual relationships and whatever's going on is to use a condom. There are lots of reasons why condoms have not been effective at preventing a large epidemic in South Africa and other places. Lots of people have done lots of better work than us on this sorts of things like gender norms and power asymmetry between couples, transactional sex, and we've been doing some work about incentives for risk and sex work. So we've shown that unprotected sex sells for a higher price than protected sex, which we think is an incentive to provide unprotected sex. I'm not going to dwell too much on that side of things today. What I will dwell on though are these different ranges of potential products which might help people protect themselves from HIV. So I'm going to talk about 5 products, all of which are antiretroviral based. They're HIV prevention methods that HIV negative people use, and they basically deliver a small amount of the very similar drug to what's used in treatment. And if an HIV negative person is able to use these products effectively, they provide HIV protection to them. So there are 5 ways of delivering this drug that we've considered in this study. This isn't a representative sample, the full sample, and it might not be the ones that are still under development. But a few years ago, we were looking at potential options. 2 years ago, and this is where the field seemed to be. So the one you might be most familiar with are the blue tablets on the left-hand side, made by Gilead in this instance, but these are oral pre-exposure prophylaxis tablets you take once a day or a few times a week if you're HIV negative, and they've been proven efficacious and beginning to be shown effective in preventing HIV transmission. Second from the left is a microbicide gel, which have been around for a bit longer than oral PrEP, but have had more mixed results in efficacy trials. The gel can be used on its own, or it can be used in combination with the pink diaphragm in the middle of your screen, which is a Silk's diaphragm. The rationale for combining these 2 products together is that you could be protected from pregnancy with a diaphragm, potentially from HIV with a gel, giving some multi-purpose protection, which is the source of us thinking through how multi-purpose protection might be attractive to different users of the products. Second in from the right is a type of intravaginal ring. These go into the vagina between every sort of 3 weeks to every 8 weeks, depending on which version you're looking at. And they don't all look like this. Some are bigger, some are fatter, some are more white, different colours. This is a fairly non-invasive looking vaginal ring. This is a contraceptive ring which we used as an example in our study. Finally, the injectable on the right hand side. This is something that doesn't exist yet. There are phase 2 trials, phase 1 or phase 2 trials going on to develop an ARV based injectable product, including with our partners at Wits RHI. So these products have the potential to increase the agency of vulnerable groups. They don't require your partner to know that you're using them, essentially. If you are in a situation where you can't convince your partner to use a condom, you can take things into your own hands, so to speak. You can use the tablet, you can use one of these other products to protect yourself. But at the moment, only the oral PrEP and the intravaginal ring have been proven efficacious in trials. A concern is their single purpose, so they only protect against HIV for the moment. When condoms are used, they're great. They're multi-purpose products. They protect against HIV, STIs and pregnancy in many cases. So we're concerned a bit about how people's behaviour might change if they're using something that's effective in preventing HIV, and how STI and pregnancy rates might change as a result. That's the concerns against substitution for condom use. And all of these products require adherence. So a condom you have to use every time you have sex. The microbicide gel, you also have to use it every time you have sex. You use it 2 hours before and 2 hours after. And trials have shown there's lots of reasons why microbicide trials might not have worked, as we've perhaps expected them to. And I won't dwell too much on them. But one of these reasons is that adherence is thought to be quite low amongst some groups, particularly younger women. Things like the injectable and the intravaginal ring, which you use maybe once a month or once every couple of months, they need less adherence, or they need less uses. So your chances of missing a dose are a bit lower, we think. So we think these newer products might be able to increase adherence. A bit more motivation about why we're doing the study we're doing. These are just some graphics from the South African HIV and TB investment case, which was run a few years ago. It uses lots of modelling. So we model, before we introduce products, we try and see what effect they would have on the epidemic. So we try and get a good picture of what's going on at the moment and what we think incidence and prevalence would be in 10, 20, 30 years' time. And then in our model, we can change things. So we introduce a product, and if we know the efficacy, we know how many people might use it, we're able to simulate how these distal factors, the incidence and prevalence, might change at the end of our time period. Now, the reason I show this is that a few years ago, the South African government and the Gates Foundation spent a lot of money producing this HIV and TB investment case. And it's one of the few investment cases I've seen, or the few examples I've seen in low middle income countries, where the results of a modelling exercise and cost effectiveness exercise have been built through into a strategic change in the Department of Health. So this is a snapshot from the strategic plan for HIV and TB, published by the South African National Department of Health last year. And it says that 13% of current funding was found not to support priority interventions. So before we did the modelling exercise, we were spending 13% of funding on things which weren't good value for money. So these should be deprioritised with funding reallocated to some more evidence-based approaches. Now, this seems really obvious, perhaps, that we should be spending money on things that work and that are cost-effective. But actually, economists have been banging on walls for years saying that things aren't an efficient use of resources. And this is one of the few examples, as I say, from low and middle income settings where it's been a success story for showing with models the impact that different interventions might have. So models are important. Okay, so I'm going to launch into our methods now. We conducted a discrete choice experiment, and the best way of showing what a discrete choice experiment is by showing you what we did. This is an example of our task. Now, discrete choice experiments are hypothetical choice tasks. Instead of asking people to choose things in reality and following them up and seeing what they choose and how they get on with using a product, these products don't exist at the moment, many of them. They don't exist in the combinations that we would like them to. So we can't explore how people's preferences and people's uptake will vary across different groups and across different products. So we asked them the next best thing. We asked them these hypothetical choice tasks, where here, this is one task. If you were a participant in our study, you would have seen 9 of these, and we would have asked you to choose which of these scenarios, product A, B, C, or the condom, would be your most preferred product. So which product profile do you think is best out of these? So on the left-hand side, we've got a product which is an injection. It's described as being 95% protective against HIV. We can see here that we've got this idea about multi-purpose protection, where there's pregnancy protection in this product on the left, and it also provides STI protection. You use it twice per year, so every 6 months, and it might cause side effects of dizziness. Moving across to product number 2 is a oral PrEP, which has got a lower level of HIV protection, but still protects against pregnancy. It does not protect against STIs, but it has no side effects. So, as I said, if you were in our study, you would be shown 10 of these choice tasks, each time asked to pick your favourite. So I'm just going to flick the slides over and show you another task. This is task number 10. And you can see that if I just flick backwards and forwards, I hope this works very well, but you can see how the attributes in these alternatives change. And it's by looking at how people choose their favourite product, which product they choose, looking at how their choices are affected by the different attributes of the products we present to people, we work out what's important to them. So here, for example, you can see the vaginal ring in this instance provides 95% HIV protection, whilst the other products provide only 55%. So if we think in this one you're choosing the vaginal ring where it's 95% protective, and in this one you're choosing either the injection or the diaphragm and gel, we think that the HIV protection is going to be quite important to your choice. But to choose that 95% risk reduction of the vaginal ring in this example, you need to choose the product which doesn't protect you against pregnancy. So over the course of the choices that you make in this experiment, we can tell what's important to you in making the choice in reality. Touch a bit about data collection. We did this field work for this study in 4 population groups. In the DCE we carried out these tasks and a bit of a background survey amongst adults, men and women in the general population, adolescent girls aged 16 and 17 and female sex workers. In Ekurhuleni Municipality, which is southeast of Johannesburg, we based the general population sample of adult men and women and adolescent girls in a township called Vosloorus. So you can see here our sampling map made from Google Images at the top, and our survey team going and carrying out the survey work for us. We've got the tablets. We did tablet-based data collection. So interviewers would hand over the tablet and people would talk through the DCE and complete it themselves, or the interviewer would complete it for the people, depending on how familiar people were with tablets and entering data into mobile phones and that sort of thing. And I'm just showing at the bottom, this is, we used Open Data Kit software, which if anyone is doing a survey and trying, scratching their heads and thinking about whether to use a paper-based software or a fancy computer system, Open Data Kit is it's an Android app you can download onto relatively cheap tablets, and it's very easy to program yourself. So this is an example of how you set it up. Each row is a different question. You set up your question, you set up where you want your variable to be called, where you want it to point for your responses. And we had the survey team uploading these at the end of every day's data collection. It was really, really useful for training, for quality control, for starting analysis early, seeing how close you were to sample size throughout. It was really, really useful to have this tablet-based data collection. So I'd really encourage Open Data Kit to anyone who is setting up a study at the moment. This is how our sampling went. So we've got 4 groups from left to right. We've got adult females, adult males, adolescent females, and female sex workers. And the final column is the total. So everything in the row will add up to the final column. We aim to recruit 200 people or so in each group, which we managed to do, a total of 812. We asked people to self-report their HIV status. So we only carried out the DCE amongst HIV negative people. And we'd expected self-reported HIV prevalence to be rather low. Amongst adult females and female sex workers, we think these numbers probably aren't too far away from what we'd expect if you did a more objective method through blood spot testing or something like that. Amongst adult males, it's tough to say, but we think that prevalence might be a bit low, that people might have been underreporting their HIV positive status. Adolescent females may not have had an HIV test, they may not know their status just yet, so we're not quite sure what that number means either. We also excluded adults who are not sexually active, and in total we had 535 people complete the DCE. Okay, so on to our results. This is looking at what people prefer in a product. So which of the products do people like? There's a clear winner across all 4 population groups. So each coloured bar represents a different population group. From top to bottom, we've got adult males, adult females, adolescent females, and sex workers. Adult males, the blue line, only chose between the injectable and oral PrEP. Now, what we see here is this clear preference for an injectable. We see that sex workers really like an injectable relative to other products. And across the other products, we see a bit of a tend to dislike for the intravaginal ring, particularly amongst adolescent girls and sex workers. Another thing to note here is that adolescent girls are this green line, adolescent females, a green line where their preferences are quite variable and quite different compared to the other female groups and compared to the men as well. Oral PrEP and microbicide gel are broadly attractive to this group, whereas adult females and sex workers have a general negative preference relative to the other products for oral PrEP and the gel. For the other attributes, we see that people like products that provide STI protection. They like products that provide pregnancy protection, but the most important thing to people is that they provide HIV protection. So this is showing how much people like the different characteristics relative to each other. And HIV protection here is shown by 75% efficacy. So an imperfectly effective product is still still very valuable to people compared to offering just STI or pregnancy protection. The other thing to note here is that adult males and adult females are again reflected in blue and red. And if we look at the pregnancy prevention set of bars, comparing how much adolescent females and sex workers value pregnancy protection compared to adult males and females in the general population, we see that these two groups value the additional multi-purpose protection quite strongly, and the same with STI protection. Okay, so when we've got our DCE data, we know what people like in a product. We're able to use that data to predict how much people might use these products in reality. Now, we would normally set up a model to do this, and we do. And we use our DCE data to inform our uptake parameter for that model. So parameters in models come from lots of different sources. They come from observational data sets, cohort studies, lots of different biological and behavioural surveys. And we use the DCE to just provide one parameter for that model, which is uptake, which is how much we think people will use these products. Because we do this, we're able to get quite a granular sense of how uptake might change across different scenarios. And we simulate 5 scenarios of introducing products here. And the key differentiation is that some of them have fewer products with just HIV protection, and some of them have these multi-purpose products included. And multi-purpose from now on I'm going to refer to as pregnancy protection. And for that reason we're going to exclude the adult males in this cost effectiveness analysis, because there's no sign of a multi-purpose, there's no sign of a male contraceptive being on the market anytime soon, or the one that can be integrated with an HIV prevention product in particular. Scenario 1 is just HIV preventive oral PrEP. So that's probably the most likely scenario for lots of these groups in the next few years. In South Africa in particular, oral PrEP's available to sex workers. Well, it's available to anyone who turns up to a clinic and asks for it, actually, but programs are focused on sex workers and delivering oral PrEP to that high-risk group. It's likely that the next group would be, or there's work going on with students at universities, so young female students, to try and target oral PrEP to them if they would like to use it next. So scenario 1 I've called current practice. Scenarios 2 and 3 I've called the next few years. So we've had some evidence from intravaginal ring trials that they are to some extent effective. The extent to which they are effective is quite variable and in general fairly low, and we're able to incorporate that in these analyses. But we model 2 rings. We model one that's just HIV preventive, and then that's in scenario 2. Then scenario 3 we simulate the impact and cost effectiveness of oral PrEP plus a multi-purpose ring, so a ring that offers HIV and pregnancy protection. Scenario 4 is the kitchen sink, where we throw everything out, everything that we think we might be able to develop. We model to see if that would be impactful and cost effective. So here we introduce all 5 products that we asked people about: oral PrEP, the vaginal ring, the injectable, the microbicide gel, and then the diaphragm, which is used with the microbicide gel. The diaphragm and microbicide gel will always be pregnancy protective because of the diaphragm element in there. Then scenario 5 is the multi-purpose kitchen sink. So this is all of the products with all of the attributes turned on, so everything is HIV and pregnancy protective. So you can see here that we've got different levels of, let's say, realism across these scenarios. And that's one of the advantages of taking the DCE approach, that the products don't exist. We can use our best guess to simulate what their uptake and impact might be, to see if it's worth continuing to develop a range of products, or if we should focus on just 1 or 2. As I said, we can predict uptake from these DCEs, and there's 2 things to take away from these uptake predictions amongst different groups. First, I'll explain the graphs. So we have our 3 populations, our 3 female populations in each graph. We have adolescent women, adult women, and female sex workers from left to right. Then in each graph we have the 5 different products along the bottom, so each set of columns represents uptake of a different product. The axes on all of the graphs are the same, so the y-axis is the top of that is about 21%. And then the different coloured bars, the blue, red and the green, represent products which have just HIV protection, HIV and pregnancy protection, and then HIV pregnancy and STI protection. And STIs is something that I'll come back to. We don't include in our cost effectiveness analysis. So really the blue and the red lines here are what we will be modelling later on. We can see very clearly that the injectable ARV, injectable PrEP will be attractive to particularly adult women and female sex worker groups. So we see that the injectable ARV is about 2 to 3 times more attractive to adult women and in particular sex workers. Once we look past the strong preference for an injectable, we see amongst adolescents something that's even more interesting, I think. That if we look at compare the height of the blue and the red lines, the blue lines are products which just protect against HIV, and the red lines are HIV and pregnancy protection. So if you look at how much the blue lines increase to the red lines in adolescent women, we see that uptake is predicted to double, and in some cases slightly more than double. And then we move from single-purpose products to multi-purpose products. Now these trends are reflected a bit in the other two groups, particularly in the injectable amongst adult women. We can see that there's a bit of a step up when we introduce pregnancy protection, but not to the same extent as among adolescents. And amongst sex workers, it doesn't make a great deal of difference what the characteristics of the products are. So we predicted uptake. I've got one slide here which has got some formulas on some equations. But bear with me. If you're interested in this stuff, I'm more than happy to talk about it more at the end or offline. But I just wanted to give you a sense of how we model impact in this setting. It's a relatively simple model. It still took me quite a while to get my head around it, but it is, I'm told, quite simple. And we use South African demographic and HIV epidemiological data to parameterize different things in our model. We describe the protection provided by each product as a function of efficacy and its use. So if you use a product 100% of the time and it's 100% effective, you'll get full protection. If you use a product 100% of the time, it's only 50% efficacious. That protection would be reduced, and the same if your adherence falls as well. I'm just going to give you a sense of how we've modelled protection in this sample. So just looking at the words above the pretty disgusting looking formula, the overall protection is really the additional protection from new products that we simulate from our DCE. We take away condom migration, so the extent to which people are going to stop using condoms because they've started using new products. And then we add the remaining condom protection that still exists. So it's just a big sum. It's just a big spreadsheet is what we're doing. It's nothing actually that very complicated. Our impacts we estimate through DALYs averted. So we estimate benefits from 1 year of product introduction. It's not a fancy model that goes for 20 or 30 years. We're just comparing costs and benefits that might be incurred from product use in 1 year. We consider DALYs averted through preventing HIV infections. We don't consider benefits from unintended pregnancies averted, and there should be a caveat here actually. The only benefits that other cost-effectiveness studies are able to assume for unintended pregnancies averted are risks to the mother's life from going through childbirth that would otherwise not occur. So there are lots of ways you could conceptualize a benefit from averting a pregnancy. The only one we're able to actually model and include is the risk to her, or mortality or morbidity risk to the mother from giving birth to a pregnancy that was unintended. So we're actually getting a very low additional benefit from a multi-purpose product outside of a variation in uptake. So we look at the DALYs averted per infection estimated for each population. We look at models with the low, medium, high HIV incidences. This is taken from South African statistics survey data for each group. We don't use age weighting in our DALYs, and we use a discount rate of 3%. We use a willingness to pay threshold of £1,175. Economists might be scratching their head, other people might be scratching their head at what a willingness to pay threshold is. Really, we're trying to get at how a health system should spend their money. If a health system's got a pot of money that's been allocated to it, it needs to work out if what it's spending or what it purchases with its funds is good value for money. If you buy one thing from your pot of fixed funds, you can't spend money on another. So we try and reflect that opportunity cost of spending your money in one area compared to the benefit you might get from spending it in another. There are lots of thresholds people use, particularly low middle income countries where government decision making is less clear. It's also not clear in higher income countries in many contexts. This threshold of £1,175 is a fairly low estimate. It's a fairly conservative estimate for a willingness to pay threshold. You may see GDP per capita figures used as a willingness to pay threshold. For South Africa, GDP per capita is around, I can't remember the exact number, it's around £3,000. So this is a more conservative threshold. Things are less likely to be cost effective in our analysis than some others. If you're interested in our cost model, this is what we included. We had some startup costs for introducing products, which included the training of providers, mass media, multi-purpose technology research and development. We include in the sensitivity analysis in the end. We didn't include that in our main estimates. Facility distribution costs, we accounted for staff time, costs of the products themselves. We assume that the cost of the multi-purpose element would just be additive on top of the HIV protective element. And we plan some costs for how the health system might change and changes in overheads as a result. And because people will be using more products, we're averting some costs as well. So if we stop someone from becoming HIV positive in our model, we're able to capture or avert the costs of them being on HIV treatment, ART treatment, and also the costs associated with planned and unplanned miscarriages and births. So this is really the summary of all of that spreadsheeting, sticking all our numbers in and seeing what we get out the other side. This is where we're at. So we've got three groups. We've got our model is women aged 15 to 24, which is the left-hand collection of bars. Women aged 25 to 49, listed as women aged 25 plus in the middle, and female sex workers on the right-hand side. The dotted line is our willingness to pay threshold. And on the y-axis, it should be labelled, but it's not. It's our estimated cost per DALI averted of each intervention. And you might remember the table of interventions. We've got scenario 1, which is the blue line of oral PrEP with HIV protection only. Scenario 2 is PrEP plus the vaginal ring with HIV protection. Scenario 3 is that MPT ring, the multi-purpose ring plus oral PrEP. Then scenarios 4 and 5 are all 5 products with HIV protection only. Scenario 5 is the all 5 products with multi-purpose protection. So the most obvious thing we see on this graph is that every intervention amongst two groups is predicted to be cost effective. So if we do any of these things amongst women aged 15 to 24 or amongst female sex workers, we think they're going to be a cost effective use of resources. Amongst women aged 25 plus, we see some variation in estimates of cost effectiveness. The blue line and the purple lines represent the multi-purpose prevention products. So we see that those alternatives are more cost effective amongst each group. In women aged 25 and over, they are more cost effective, but still not low enough for us to call them cost effective with the willingness to pay threshold that we use. Finally, the multi-purpose prevention scenarios amongst sex workers go negative. So in the right-hand side, the blue and the purple lines go below the y-axis of 0. Now this means that they are cost-saving and they have a positive benefit. So we see across the board that these multi-purpose protection options will be cost-effective. And this is slightly more complicated, but let me talk through this table. So PrEP is already here. So we're assuming in our other analyses that our comparator for our introducing new things will be the current level of condom use. But as I said at the start, PrEP is available to sex workers already. It might be available to different groups. So the top line of numbers here it assesses the cost effectiveness of adding a single purpose vaginal ring to PrEP. And if we go across that first line, where it's shaded in green, it's below our threshold, and where it's shaded in red, it's above our threshold. It's not cost effective. So looking across at our central incidence values, so we've got again 3 columns within a column. Assuming central incidence, we find adding a vaginal ring to PrEP at the moment will be cost effective in younger women, and it will be cost saving in sex workers, but we see that it's still not cost effective amongst older women aged 25 to 49. So adding a single purpose vaginal ring to PrEP would be cost effective amongst the two high risk groups that we consider, younger women and sex workers, but not cost effective amongst older women unless incidence was high. Adding a multi-purpose ring, however, is cost effective across the board, even amongst older women, older female groups. So adding the multi-purpose ring to PrEP would be cost effective. And we also compare our hypothetical kitchen sinks of adding the multi-purpose kitchen sink across all groups to comparing that to the single-purpose kitchen sink, and we actually see something that's a bit different here. It's actually cost effective amongst. Okay, so the bottom three squares in red on the right-hand side should be green. They are negative numbers in sex workers, so they should be cost saving. The message is that it's cost effective to add a range of multi-purpose products to our single-purpose range. So the multi-purpose technologies are adding impact, and they're saving us enough cost for them to be cost effective. So I'll conclude just before I start running out of time. We find that MPTs, multi-purpose technologies, are likely to be cost effective amongst younger women, aged 16 to 24, 15 to 24, and sex workers. The most effective, or the most cost-effective scenarios were those with MPT products included, and it's likely cost-effective if we're able to add a multi-purpose ring to PrEP provision. And other scenarios are more nuanced. It really depends on the incidence, HIV incidence amongst the group that we explore. And actually, all of our model is very, very sensitive to our assumptions around incidence. It's by far the biggest driver of the impact that we find in our cost-effectiveness estimates. We can change incidence in each group by a very small number, and it has quite a large impact on our results. Another thing to note is that although these products are cost-effective, we predict them to be cost-effective, the overall impact is likely to be low. So our most effective scenario is when we throw every product with every multi-purpose attribute that we can at our population. That scenario where we model that predicts a 19% incidence reduction amongst younger women and 8% amongst older women and female sex workers. Now, that's likely to be fairly burdensome to the health system in funding, but the UNAIDS 1990 targets are estimated to lead to a 48% reduction in incidence in general. So actually, even with all of these investments in these multi-purpose technologies, we've still got some work to do to reach the incidence reduction that we'd expect from the 1990 targets. So I'll finish my presentation there, but I'd like to acknowledge all of our study participants who gave up about 45 minutes to an hour of their time and all of their efforts in completing our survey. And we're totally indebted to the interviewers and the staff of Progressus Research and Development who are based in Johannesburg and did a really great job gathering our data, but also giving us great insight into developing our tools and testing our tools and seeing how people responded, and just provided energy and enthusiasm throughout. The Bill and Melinda Gates Foundation funded our fieldwork. The Economic and Social Research Council funded my PhD and my time. And the cost effectiveness elements were funded by PATH through USAID. So we're indebted to them as well for allowing us to do the modelling elements as a result of the research. So I'll say thank you for listening. If you've got any questions or queries, I'll be happy to clarify. And if there's anything we don't pick up, then drop me a line and I'll be happy to speak more fully.
Matt, you talk about, on one of your slides, you have the cost effectiveness of each of your three populations presented separately. And you mentioned if you were to intervene among all three groups at the same time, it would be cost effective, but actually the least cost effective group would be among adult women. It would be kind of interesting also to show the first step. It looks to me like introducing new prevention methods is kind of a no-brainer among FSW, and then we could look at incremental cost effectiveness among adolescents and then adult women. And in that case, once you have laid the foundation, having all those fixed costs, I wonder if the marginal cost of reaching out to adult women would be cost effective. Have you looked at the analysis in that way?
No, we haven't. It's a really good point and something we should investigate more now. It was actually difficult. There wasn't a great deal of methodological guidance about how we could allocate these fixed costs to the different groups. And another example is that the female sex worker group is much smaller in terms of absolute numbers than the other two groups. So we've really assumed that the fixed costs are shared across the greater number of general population groups. But that's certainly something we should look at more.
Okay, that's great. Thank you so much. And we have a question from Bruce McKay. I'm going to read it out to you. When you use the term adolescent, do you simply mean they were age X to Y? If so, which ages? The later slide suggests it was 15 to 24. Which few people in this field would recognize as a definition of adolescence? So I guess he's suggesting that is too wide. What differences were there between the younger and older members of this age group? 24-year-olds are very different to 15-year-olds in their experience, knowledge, and attitudes. So that's the first question. And the second question is, did you test whether different ways of presenting the discrete choices produce different patterns of responses? We know from the ESRC program on risk that many people have a poor understanding of both risk and percentage and respond very differently to different graphic representations of numbers such as percentage. Is the value given by adolescent females to HIV prevention 75% over pregnancy prevention 25% comparable to the responses to other surveys in South Africa? I ask, sorry, it's a long question. I ask because in other sub-Saharan countries, it is usually the other way around. Why did you not consider a stage introduction of new products? So that's a question 3. Do you want to answer the first 2, and then we'll move on to the third question?
Sure, let me get stuck into number 1 and number 2. So thanks, Bruce, really good question. I perhaps wasn't particularly clear of how we moved from the discrete choice experiment to the modelling, which I think will answer your first question. I use the term adolescent. I do simply mean that the adolescent girls were aged 16 and 17. So that's my terminological laziness by calling that group adolescent. You're right that in the modelling screen the modelling slide that's on screen at the moment, the younger age group is women aged 15 to 24. Now, the reason we've modelled in these two groups of women aged 15 to 24 and women aged 25 to 49 is the availability of data on other things that aren't uptake amongst these different groups. So the South African Stats Bureau release their HIV incidence and sexual behaviour statistics in certain age bands, one of which is 15 to 24, and the next is 25 to 34, and 35 plus, and so on. So the only parameter we're getting from our DCE is uptake. All of the other data is coming from other studies and statistics released by the South African government. So we wanted our model to reflect real life as much as possible, so we parameterized our model based on those age groups, the 15 to 24. And what we've had here is we've sort of weighted in the expected number of women aged 15, 16, and 17. We've assumed that their preferences would be the same as what came out of our DCE amongst those younger people. Women aged 18 to 24 in that group, we've assumed that their preferences would be the same as younger women in the general population. So we're able to account for that heterogeneity in our uptake predictions. So although I'm presenting in this slide the cost effectiveness of the scenarios for women aged 15 to 24, we accounts for their variation in preferences across that whole age range from the DCE. The question about testing whether different ways of presenting the DCEs produce different patterns of response is a really good one, and there has been lots of research, not just in the study you mentioned, but around how we present things like risk percentages and how people react to graphical representations of those. A recent study has just come out that's shown that people don't gain any extra, well, people don't respond differently to a choice experiment with a risk array. So like we've shown the numbers of people shaded in, some are a different colour to others. People don't respond differently to those compared to just a really big number giving a percentage. So that's saying that people don't respond differently in these choice experiments for a picture to a number, but whether that picture or number actually means what we think it means of how this idea of risk gets over to people is up for grabs really. A lot of qualitative work is done with these. We weren't able to do some in this specific study, but it is a risk that we acknowledge that people might not be fully comprehending these attributes as we think they might. Your third question, is the value given by adolescent females to HIV protection over pregnancy protection comparable to other responses to surveys in sub-Saharan Africa? I ask because in sub-Saharan African countries it's usually the other way around. That's a really interesting question. I haven't, I'm not familiar with those studies, so I would like to see them, and it would be interesting to see if any of our results are similar or different and explore why that might be the case. So if you've got any direction for me on that, that would be great.
Can I suggest that we get back in touch with Bruce, and I'm going to propose that we move on to Kate Harrison and then Liz's question, and if we have time at the end we come back to Bruce's question on stage introduction. I think it's really interesting, but I want to make sure to include everyone's participation in this. Bruce, forgive me. So Kate Harrison asked, why in the discrete choice experiment PrEP was presented as also preventing pregnancy when it doesn't, and vice versa for the diaphragm?
Yes. So this is the slide I think you're referring to, Kate. Thank you for the question. The way these DCEs work is that everything is, we give people these repeated tasks, and the tasks look the same in that there's 4 columns. In this, the left-hand 3 columns, which represent the new products and not the condom, all of the boxes in there change according to an underlying statistical design, which allows us to maximize the information we get. And it does that by making sure that people make difficult choices between each of the attributes. So each attribute is each row, so people comparing HIV protection and pregnancy protection. To do this, we give people perhaps sometimes unrealistic scenarios. So like you pick up here, oral PrEP, we're describing that it does prevent pregnancy. And the diaphragm and microbicide gel, we describe it as not preventing pregnancy. And now, at the moment, you're right, oral PrEP does not. The diaphragm does. But actually, in the next scenario, where are we going here? Here we're showing that oral PrEP still does. The vaginal ring doesn't, but the microbicide gel does. Now, the changes to the attributes of what we show people on the pregnancy prevention row are happening independently to the product at the top. So what we're able to do is work out, regardless of products, regardless of what's in that top row, whether it be a tablet or a gel or a diaphragm, we're able to look at how important pregnancy protection is compared to the other attributes. So we're not saying to people in this example that oral PrEP is always going to prevent against pregnancy, the injection will always prevent against pregnancy, but the diaphragm will not. But what it's allowing us to do over our whole study, over our whole DCE, is look at how much people value pregnancy as an intrinsic attribute to a product. Fern, would you like to add anything there?
No, but we are hoping in the future to have dual protection products. So that's the aim of why we wanted to know this. I think that was the core thing as well, is that it may not currently be possible, but there is research being done with the hope of having dual efficacy products. Great. And Liz Furon sent in a question asking about if you can account for other reasons that people might choose to use one product over another in a DCE experiment, factors other than HIV prevention, pregnancy protection, and STI protection, thinking of social norms. Can you tell us some of the other explorations that you've done that were other drivers of demand that you've explored?
Yeah, absolutely. So you're right, there are lots of things which can affect people's preferences for these products, not just how they're described. What we do a lot of, it's results that I haven't presented here. I've presented our sort of basic results where we look at the sample average. When we delve deeper into each group, we find that there are some variations across groups and across socio-demographic characteristics. You sent me scrambling for a document to find a table that I'm just going to refer to. And I'll start with, there's, and if you're interested, I can share with you the paper where this is published. I think it was sent out in the Strive emails. So if you, it's published in Medical Decision Making, and if it's behind a paywall, I'm more than happy to send you the PDF. We've got groups, adolescents and female sex workers. There's not a great deal of variation in preferences amongst those two groups. I'm wary of using the word adolescent now, but in our sample of the women aged 16 and 17, we don't see a great deal of variation in preferences for products, except a distaste for the vaginal ring as a product in itself. We see a great deal of variation amongst preferences for the multi-purpose elements of the product. So there's, we conducted a latent class analysis where we showed that there's a group of young women in our sample who weren't making choices based on the HIV protection that the product was offered. So whatever was going on in that HIV row, they weren't paying attention to it, and they were really focusing on the pregnancy protection and the STI protection offered by a product. There's another group of young women who were just paying attention to the HIV attribute and to an extent the pregnancy protection, but they didn't really care about anything else that we used to describe the product. Amongst the other groups, that was the biggest sort of source of variation within our sample that we found. That there was some people who cared loads about HIV protection and not a great deal about other characteristics of the products, and some who really just wanted a contraceptive that worked. And also provided STI protection. So I hope that answers your question.
Matt, do you want to talk a little bit about the exploration that you've done around some of the structural drivers and preferences?
Yes, I will scrabble for my other paper. What we found,
that is part of, yeah.
Yeah. If you give me 2 seconds, maybe you could throw a question at me in the meantime.
I'll introduce what you've done. So the way that DCEs work is that you can also include interaction terms of socio-demographic background as well as experience, and that you can test if people with different experiences have different preferences. And as part of Strive, you can also look at experiences with violence and alcohol and such factors. And Matt has done an extensive analysis of these drivers, which, if you can't find it now, we can
no,
talk about.
So I've got it up here. So we've looked at how a few characteristics affect people's preferences. So how characteristics of different people affect the likelihood they are to choose different products. We find that we looked in particular at these associations with choices of the intravaginal ring and oral PrEP. Now we find people are more likely to choose oral PrEP if they are younger, and also if they're more likely to have more than one partner in the last 3 months. So younger women who are more likely to be or likely to have more than one partner in the last 3 months are more likely to choose oral PrEP. Whereas they are less likely to choose the ring, so they're more likely to choose the ring than PrEP. We find alcohol use at-last sex is actually negatively correlated with the ring and oral PrEP too. So we see that alcohol use is going to really reduce demand for these different products. Interestingly, we still find that condoms, amongst women who have more than one partner in the last 3 months, and this sample's here reduced to women under the age of 25, we find that women with more than one partner in the last 3 months are more likely to choose the male condom option. So there's still reliance on condoms despite this, shiny new offer of new products offering all of their protective capabilities.
Great, thank you, Matt.
I would just add one more actually. Sorry, one more quick one. We also looked at variation in preferences for people who've been exposed to intimate partner violence, and it's a similar message really, that we find that the uptake of newer products, so whatever the new product is more likely to be higher amongst people who have been exposed to intimate partner violence with a lower reliance on condom use. Sorry, Fern.
No, absolutely, and that's, I think, a really important message for this audience, in particular within the scope of the STRIVE work. Thank you, Matt. Mitzi, I think the last question is for you.
Okay, so thank you, Matt, for a great presentation. As somebody who's been involved with microbicide research and PrEP research for many years, my heart sank slightly at the DCE results for PrEP preferences, but raised slightly in terms of young women's interest in vaginal microbicides. I'm interested in how you are using your evidence in terms of informing some of the decisions around product development, because I'm very aware that the NIH consultation finishes today, and they are proposing withdrawing all funding from vaginal microbicides. So I wondered if you'd been able to package this in a way to inform product development.
That's a really good question, and it's something that we haven't actually been able to focus on too much. And the NIH consultation you mentioned, we haven't put any evidence in for that, but I'll start by saying that. What we have been doing is working with it's called the IMPT, and it's I can't quite remember what the acronym stands for. It's Innovations in Multipurpose Preventive Technologies or something. It's an advocacy group run in the States, funded a lot by USAID, who work with lots of different partners, but work across the range of gathering end user data like we've gathered here, and working with producers of potential multipurpose prevention technologies, working closely with donors to try and make a case for multipurpose prevention. So we've done a webinar very similar to this, actually presenting these data to that group and interested parties. We had about 100 people on the webinar listening in from a range of sources, from donors, from implementers in the field, from NGOs and other interested parties. So we haven't reached the consultancy that you mentioned there. I think we could do a lot more, and if anyone's got any advice of how we can get this evidence out there outside of our nice journal article, that would be much appreciated, because I think there's some strong arguments here for and against different approaches.
Thank you very much, Matt.
So thank you very much to Matt for the presentation, and Fern for chairing this session. And remember that all of our learning labs are available on the website. And look, we will be sending out details of the next learning lab in January shortly. No, in December shortly, sorry. Okay, thank you all very much. Goodbye.
Thanks, Mitzi. Thanks, everybody.
Thank you, everyone. Bye-bye.